Welcome to the Critical Care Obstetrics podcast. I'm Dr. Stephanie Martin, Medical Director at Clinical Concepts in Obstetrics, and I'm here with my colleagues and partners, Dr. Suzanne McMurtry-Baird, our Nursing Director, and Julie Arafray, our Simulation Director. Today, we're going to kind of take a little bit of a different approach and talk about what we call the can-do culture. And really what that means and how it can impact your unit. So before we get into it, we want to talk about and remind you about a few ways you can learn with us beyond the podcast. We have our CCOB Academy, the Critical Care Obstetrics Academy, which you can find on our website, clinicalconceptsinob.com, where we have a full library of online courses to help you build your confidence and skills in managing high-risk and critically ill obstetric patients. You can also join our community at Patreon, patreon.com/CCOB, where your support is really crucial to us helping us continue our mission. On Patreon, we have exclusive videos, learning opportunities, and live sessions to interact directly with us and get deeper teaching insights and teaching pearls. You can also watch us on our podcast on YouTube. Just search for the Critical Care Obstetrics podcast and, pick a platform or two or three and connect with us. So, Julie, I want you to start introducing this topic to our audience. What is can-do culture? What do we mean by can-do culture and how does it impact the unit? Why don't you tell, I think you have a really good story to kind of introduce this.
Well, I remember I started nursing in 1980, so I remember a long time ago. And the first university hospital that I worked at, we had, of course, more patients than we had rooms. So they took a room that was closer to the nurse's station and turned it into a patient room. But the problem with this room was that it had a window, and my memory is a little bit foggy about it, but I remember there was a window and we asked for drapery for that window so that people can look in and see the patient. Of course, we were told, well, no, really. We don't have, I don't know what their excuse was, but there was no room for drapery. So a bunch of the nurses got together and we took some of the older baby blankets. One of the nurses was a really good seamstress and we made our own. We sewed our own drapery out of baby blankets and hung it in that window. I think someone brought a tension rod in. I don't know what. It was ridiculous. But they were really cute because, like I said, she was a very talented seamstress. And it was just such a contrast to me when I worked for a short time for a medical device company, and I worked with a group of my peers that were clinical nurse specialists, and I had met several of them. I had worked with some of them before. It was a great group. And we'd sit around and talk with the sales reps about, okay, well, if we had this, we could do this in our presentations. It was on your doorstep. FedEx overnight delivery the next morning. And I thought, oh my God, what a contrast between what you kind of do in the hospital and what the business world, the support and, sometimes the expectations in the business world. I don't think the expectations are any much different, but the support, I found it to be dramatically different.
It's night and day.
Yeah.
It's true. I mean, it's true. I've been in the same situation where you don't have the resources that you need, and nurses and physicians they just make it work.
Yeah.
But I've seen a lot of that in nursing. We just had a snowstorm here in Nashville, ice everywhere, and people are still without power this week. It's been really tough on so many people. And I had a nurse I saw on social media that I've worked with for, 40 years. And she was cooking dinner by putting these little tea candles or those little votives candles in like a pan and then a rack over those candles and warming her supper up in a pot over the candle flames. And she said she kind of had a little candle, maybe needed some therapy over that to quit buying so many, but they were coming in handy because she was making it work. And we do that in the hospital too.
All the
And
time.
all the
Yeah.
time.
Yeah.
And because you don't have the supplies you need, because you don't have the equipment that you need, and you make it work because we can do it. And it was almost like a challenge sometimes. "Oh, I can't get a K-pad? Fine." That was when we could do this and before there were some poor patient safety outcomes. I remember microwaving linens, wetting the linens and putting them in, you know, something like a Chucks or something and taping it up and making our own heating pad, which is not safe.
No.
But we didn't have another option,
Mm.
sometimes when we could not get the supplies and equipment that we needed. And it's
Well,
not good. I
that's
mean,
a great example. I can share a personal experience of that, like the heating pad experience, where the nurses are not given the supplies that they need for the patients, even and so the patient's suffering. So I actually had an ultrasound technician one time who had to have surgery and was having shoulder pain, and the nurse was trying to help her relieve the pain. She didn't have a warming pad or a heating pad, and they felt that was what would I assume they felt that was what would be helpful to relieve the pain. And she did exactly like you said, some sort of jerry-rigged, heating pad contraption, and the patient got third-degree burns and had to have
Mm.
skin grafting because of that. So that's a great example of a can-do attitude. Great intentions, trying to make it work for all involved, no ill intent at all, resulting in harm,
Mhm.
yeah,
preventable harm.
Yeah.
which is what is we're talking about today
Yeah.
really is that attitude sometimes can lead to patient safety issues and poor outcomes because we are making it work.
Yeah, I wanna remember later to talk about I think there's patient safety for sure that we're gonna dive into, but there's also personal well-being of the staff themselves, the physicians and nurses and everybody around them who's making it work, that it impacts their well-being too. So maybe let's just save that nugget, so we
Mhm.
don't forget to talk about that aspect of it.
Yeah.
But like in the office, for my whole career, when I've been running practices or, the ability to make decisions about scheduling and all that kind of stuff, one of the ways that I would try to combat this can-do attitude, it's hard as a leader because you want to support that kind of willingness and that kind of teamwork and that kind of energy in your practice, but it can create real problems. So in the outpatient setting, for example, this has been one of the things I've preached for forever. They're constantly the patients, the staff, the whoever, the man is wanting you to just add a patient on. You find a problem, add them on. This is an emergency, add them on, add them on, add them on. Or a patient's late, 30 minutes, 45 minutes. We're just going to fit them in, right? And my follow up to that is always, okay, we are providing fantastic service for that one individual and horrible service for everybody else on the schedule who was on time,
Mhm.
is waiting for their appointment, on and on and on. There's a downstream effect of allowing that, and you can plan for the quote unpredictable. Like if you're adding patients on all the time, you accommodate that in the schedule. You have unfilled appointments in the schedule to let people add on. So that's what happened. And you create rules around it and all that kind of stuff because that can-do attitude has a downstream effect. Now someone who was 15 minutes early for their appointment is 45 minutes late being seen because we've gone great above and beyond for one patient.
I think I think your point is well taken, and I think that many times when we are in this like can do attitude, you don't realize all the consequences of it, whether it's patient safety, whether it's your own well-being. I think there's a lack of awareness, maybe number one, that you're even in the can do mode because maybe sometimes you operate that way most of the time. But I think there's a real lack of understanding of the consequences that can happen because of a can-do attitude. And I know those are the things that I always try to pick out in simulation, because it's letting people be aware, hey, this is something that I'm doing because I don't have what I need. And then that's what I like about interprofessionalism, because then the physicians can look at the nurse and go, well, this is the impact it has on me. Or the anesthesiologist will go, well, this is how it affects me. Or for one of those physician groups, the nurses can say, this is how it affects what we're going to do for the patient. So there may be all these unintended consequences of this can-do attitude that you aren't even aware of.
No, for sure. I mean, it an example of that may be, you've got all these patients. Maybe there's a patient that's not quite sure you want to send home in the OB triage area. They want to wait until morning to go home to make sure they don't change their cervix again, or, you know, and you've got patients that are backing up in the waiting room because you don't have a bed to put another patient in. And instead of listening to your assessment or whatever, you are still, kind of starting that train of how it might affect upstream or something. And that's probably a bad example of a patient making sure they're not in labor. But let's say you ruled out rupture of membranes, but the patient wants to stay there, whatever. But really, they could go home, and instead you could have that bed for possibly even an active laboring patient that's in the waiting room waiting to be seen. So it just kind of backs everything up. And then if you don't have enough, beds, then you're just adding on, adding on, adding on. You can't do any more add-ons. You don't have a bed. Unless you're like the emergency room, and then you just put them in the hallway out in front of the nurses station, which is I think everybody saw during COVID and in some busy emergency rooms, and that just blows me away. You'll walk in an emergency room and you'll see like a hand and like a piece of computer paper with the letter A on it and then B slapped up on the nurses station window, and two stretchers laying there. It's like, those are
Yep.
patients.
Yep.
It's slot A and slot B.
I think that's really kind of a perfect example, because some of the most bitter discussions I think I've seen has revolved in the hospital setting, has revolved around closing the unit to
Mm.
patients.
Mhm.
I mean, bitter
Mhm.
discussions, because it's like, no, 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 we aren't, maybe the NICU is saying we haven't reached census, and OB saying, well, we can't take any more patients, or vice versa. The NICU's full, and OB's like, hey, we've got beds, we could accommodate patients. And I think that's that typical not really understanding. And I've seen it between physicians and nurses. Physicians going, oh, that board doesn't look bad. We can take 2 or 3 more patients. And the nurses going, I don't
Yeah.
understand what's going on here, because I don't have enough nurses to take care of these patients. And I think it's just maybe a lack of understanding, or an inability to communicate. And sometimes I'm sure it's driven by other forces as well, maybe financial or administrative. But it's just that can do attitude. No, we could do more. We can take a few more patients. We can
Well,
I've seen actually stretchers out in the hall with those collapsible, room dividers
mhm.
around the
Mhm.
patient. The patient's having a baby.
Well, I think these things are really, really common in healthcare for a couple reasons. First, healthcare teams are generally, we went into healthcare for a reason. We're not sociopaths mostly. We truly have the patient's best interests at heart. We want to find a way to make it work for the patient. We don't want to say no to the patient. We want them, figure this out. But there are other pressures. There's financial pressures, there's scheduling pressures, there's all that other kind of stuff. But when you don't have structure and clarity, like just take, for example, level of care. Like if you are an OB hospital and you don't know your level of care, then you don't know your scope of service. You don't know what you say yes to and what you say no to. Your NICU does. Your NICU knows exactly who they say yes to and who they say no to. They know exactly what their staffing standards are and they adhere to them with incredibly rare exceptions. At least that's been my experience. And the rare exceptions are the temporary while they're transferring babies.
I think it's the exception that people know what their maternal care level of care
Absolutely.
is. I mean, when
Agreed.
we ask, I mean, they're like, well, we're a level 2 NICU. No, I didn't ask you about your NICU. I asked you
Yes.
about your maternal level of care.
Right.
And they don't know.
Or they think that the level of care means that defines their scope.
Right.
They're very different things. And so if you don't, I mean, you should literally have a list of this is what we do here.
Right.
Like I tell the story a lot where, when we're given lectures and stuff about like in the NICU, okay, if you just take a NICU, for example, or even a trauma, okay, if you're a level whatever 1 trauma center, you know what you take care of. It's the reverse of our world. It's the highest level, right? If you're level 3 trauma center and a gunshot victim comes in, there's no one in the ED going, oh, I did this in residency. I got this. Nurses, y'all figure it out. We're going to take care of this. I'm sure one of the surgeons will come see the patient. Well, let me call around. Or a 24-weeker delivers at a level 2 NICU. There's no one in the NICU going, I got this. I've seen this before. I can handle this. Nurses, y'all figure it out. That's what happens in OB all the time. It's like someone comes in with some medical condition or whatever condition in pregnancy, and they're very high risk. And everybody in OB is like, ooh, the OB is like, I'm comfortable with this. I'll take care. I've seen this before. I'll take care of it. Nursing, y'all figure it out. And then shift by shift, the nurses are trying to decide if they have staff that they're comfortable taking care of that patient.
You heard yourself say the same thing over and over again. Nurses,
yes,
you figure it out.
Exactly. Mm-hmm. That's a common physician perspective. The physicians just expect the nurses to figure it out because they do.
Yeah. And then the nurses do it. And then later on are like, I shouldn't have done that. Or do we do that here? I've never had one of these patients before. I just, I don't know that I'm comfortable doing that, but they do it anyway because the doctor admitted them. And
then 24 hours later, we're transferring her out because no one's comfortable taking care of her. And that doctor's gone.
Yeah. Well, I think we can be a victim of our own success and can-do attitude, because what I think is very scary is when you take those patients that you don't have a resource for and things go just fine. And you think, oh yeah, we can handle this. This is, no problem. Well, that's my old adage from NASA, luck is not a plan. And that was lucky. You were lucky. Nothing happened to that patient that your hospital couldn't handle at that time. But that's not going to be true for every single patient. And you get this false sense of what you can handle based on previous lucky patient encounters.
Give you an example of that. Patient with a known cardiac condition comes into labor in a rural level 1 facility. Needs continuous ECG monitoring during labor. Probably needs some other things as well, but her needs aren't really recognized because they're not really completely assessed because they don't have the resources, the specialists, the everything to even know what they don't know, right? But the can-do attitude, this is an under-resourced area, a patient with limitations in access, et cetera. So we are going to make it work for this patient so she doesn't have to go to a hospital farther away, be away from her family, et cetera. And so we are going to figure out how to do continuous ECG monitoring in labor with no specialists, no plan for how it's going to be interpreted or reacted to. And then when everything goes well, we're very proud of ourselves for doing this instead of understanding that could have been a near miss, that we were not doing the patient any favors. Yes, she stayed close to home, but that's not the safety is first.
Well, yeah, because it's more than just putting her on a continuous ECG monitor and even having a nurse sitting there that can interpret it or sending the data to a telemetry unit that can be looked at there. Number one, you're probably not following hospital policy. of the nurses that are required to interpret the strip and document on the interpretation.
And that's not ACLS.
That's yeah, definitely. They've never been trained to do that. And yeah, exactly. That's not ACLS. It's kind of like, sure, you take ACLS. Congratulations, you now know the lethal arrhythmias, but you don't know anything about the other 50 in between. It's kind of like putting a patient on a fetal monitor and say, in the ICU and saying, let me know if it goes above 160 or below 110
Right.
and walking off, because nobody in the ICU is going to be able to interpret what's going on with anything between that 110 and 160. And that's not standard of care. So it's more than just the ECG, like you said in the cardiac example. What do you do with the data that's coming out of that machine that just because you put it on the patient doesn't mean that you know what to do about that information?
And then you set the precedent in your unit that this is what we do here. And so
Yeah.
now the next patient and the next patient comes in and the team is like, or the physician, I'll just say, is like, you guys have done it before, figure it out. We're doing it again.
Yeah.
And now all of a sudden we take care of cardiac patients when we don't have resources to take care of cardiac patients. So it creeps.
And I know that it's probably a huge patient dissatisfier to go to a larger city. The hospitals are more complicated. It's
Yeah.
not your hometown. But I think there's a lack of really explaining to the patient, listen, if something happens and we don't know, that potential, we don't have the ability to take care of you in a safe manner that this hospital has because they have an cardiology department who takes care of obstetrics, or they have an OB anesthesiologist, whatever it is. I think patients just don't understand that. And I think there's a little bit of pride or hubris in hospital systems, like, oh, we can handle anything. We can handle it. We're a full service hospital. We can do it all. But, is that actually best for the patient? And I think that's where it kind of strays from doing what is right from the patient for the
Yeah.
patient.
I remember being in a hospital that we were evaluating one time. This was a while ago. And I remember a director saying, we need to be a level, we're a level 4, but they are not evaluating us at a level 4. They're only evaluating us at a level 3. And another comment from the leader was, and we should be a level 4 NICU too, but we're not. And I said, well, do you do ECMO? Do you do cardiac babies or whatever? And they were like, nope, no, we don't. And I'm like, then you're not a level 4 NICU. And it was like, do you have a, placenta accreta spectrum disorder, program? Do you take care of cardiac patients? How is your ICU? Nope, we don't do that. I'm like, then you're not a level 4 maternal care center either. So it's that saying,
Your level of care is not determined by how sick your patients are. It's
right,
determined by how prepared you are to care for your sick patients.
right.
Yeah.
You don't have the resources. You don't have the systems worked out. You don't have the knowledge. And that shows, again,
Mhm.
it's almost like you said, Julie, it's like a bragging right or something for that particular hospital. It was to be a level
Marketing.
4 and for marketing and for attracting patients to your service. But why would you want to attract patients to your service when you can't adequately care for them?
Well, I can tell you, and Suzanne, you'll echo this, on the flip side, when the lawsuit happens, because a bad outcome has occurred, then the patient is always, typically claiming, and many times appropriately so, that if they had known, they would have wanted to go somewhere else. It's unusual for patients after the fact to say, oh, I get it, I didn't want to leave that location. The patients want the best care possible. There
Mhm.
are definitely challenging situations. You're your obligation is to make sure that you have the resources to take care of the patients, and that should not be determined at the bedside on a case-by-case basis. The overwhelming majority of situations that you are in or your team is in can be discussed and planned for ahead of time, and you guys can decide, do we have the resources or do we not? And maybe you want to, but you don't yet. Well, that gets tabled until let's take a CREDA. If you want to handle a CREDAs at your facility, awesome. Table it until you have a program established that meets all the current guidelines. If you want to take care of cardiac patients, you better make sure that you have all the things that are needed, including a cardiologist and more than one who is comfortable taking care of pregnant women. You can't suspend your cardiology program when your cardiologist goes on vacation.
And MFM too.
Yes, you have to have an MFM.
Well,
Yeah.
and I think too, not only do you have to have those resources, but you have to have them organized. I remember being in a facility that had the resources, but they weren't organized. And I walk into labor and delivery for my shift. It was night shift. And they're like, well, you've done high risk before. We're going to put you with this patient. I'm like, okay, what's her story? Well, she just had bypass surgery. I'm like, has she been seen by a cardiologist? And nope. Okay, we have cardiology on staff, right? Yeah. Well, can we give them a call? Well, nobody. Well, it's kind of night shift, and I'm like, she's in labor. So and what did they have? I told them, I said, hey, I need MFM called, and I need at least a pulse oximeter. I'm old, so we didn't have pulse oximeters and all. And of course, this patient came in completely before her due date. All rooms were full. So we're in a room without oxygen, without suction. So I'm like, okay, I need oxygen tank. And here's this can-do attitude in me. This patient should have been transferred. There was no talk of that. I can't transfer a patient as a nurse. So what am I doing? The best I can and filling out an incident report. Hey,
Yeah.
this was awful. This could have easily gone the wrong way. Particularly since, thank God, I had a lot of experience taking care of patients who had been lined. And even though I didn't have a pulmonary artery catheter at that point, probably may not have needed one, I at least had a very solid foundation in non-invasive hemodynamic assessment and understood the parameters.
Right.
I'll give you a huge example. A couple things. First, I think night shift has a even bigger can-do attitude than the day
Yeah.
shift.
Yeah.
Absolutely.
And the issue with that is that you've got a lot of younger nurses sometimes on the night shift. You have less medical staff in-house on the night shift. You have less ancillary services on the night shift. But I think we prided ourselves when I worked night shift
Yeah.
on being able to do anything,
Yeah.
right? And we were a great team
Yeah.
on the night shift.
Yeah.
But it was much more of a can-do than the day shift. Day shift be like, "Yeah, we're not doing that." And they'd be like, "Okay." Night shift's like, "We can do it,"
Yeah.
number
Well,
one.
Go ahead.
And number two, another example of this can-do when, outside of like a cardiac patient is that patient who needs an arterial line.
Yes.
And we hear this all the time
All the time.
that you're doing arterial lines in a non-ICU, which is, if your labor and delivery is not designated as an ICU and you are not trained to manage invasive hemodynamic monitoring, and all of a sudden you have a patient come out of the OR with an arterial line and vasoactive medications keeping our blood pressure up, that's outside of your scope. And the nurse's response is, "Oh, we can do it because anesthesia is responsible for the arterial lines." Like, they're watching it. And I'm just like, "Oh God." No, they're not. No, they're not. That comes up all the time.
All the time.
or you get pushback from other nurses on other units going, "What? It's just an art line. It's just
I
an
know.
art line. Come
Well,
on."
but from the ICU, but they certainly don't do arterial lines on a regular
No,
med
I know.
surge floor, They're always
Mm-hmm.
in an ICU setting, and we're we still hear that. And then you'll hear nurses say either anesthesiology is responsible for it and they're watching it, which again is such a violation of standard of care. Or they're like, if you'll just set up the lines, then I'll watch it.
Yeah.
Oh my gosh, setting up the line is the easiest part of an arterial line.
Well, I think I'm imagining that there's some nurses listening to this who are like, okay, guys, this is all fine and good, but what the heck am I supposed to do about this? Like, I can't say no. Like, someone's going to go on shift tomorrow and they're going to have a nurse on labor and a patient on labor and delivery that comes out with an art line and they're going to be like, oh my God, I've never been trained to do this. I now know what do I do? These are real dilemmas. And I think it's a symptom of lack of clarity of what you do. What is your scope of service for your unit? What do you take care of? What do you not? Like, other units in the hospital probably know this. They know who can go on a med surge floor, who's going into a step down unit, who's going into the intensive care, who's going into medical intensive care, who's going into surgical intensive care. These things are more likely, I can't say they are, they're more likely to be clearly outlined in other units than in the obstetric units. But it always starts with that kind of clarity. Because as a nurse, you can't say, you don't have a lot of authority behind you to be able to speak up and say, but we don't do that here. If there's nothing that says you don't do that here,
Yeah.
you
I
can
tell
say
you.
what your scope of service is. So Suzanne or Julie, can y'all talk to that?
Well, Julie, do you want to tell them the story about how we started our OBICU and the rationale behind that? Do you remember that?
Gosh,
And
I remember that when we had patients on other units that we weren't meeting all the time the obstetric standard of care. But I'll let you, because you were in management then. I was just running around taking patients, going
yeah.
crazy. So I know you had much more to do with it than I did.
Well, the nurses are the ones that said and made us and take care of this issue because we kept having patients that were needing invasive hemodynamic monitoring. And we were taking an entire nurse at the time to go up if they had another unit, a patient in another ICU, to go up and do the uterus, be the uterus nurse, do the fetal monitoring. But they needed invasive hemodynamic monitoring, and nurses got together and they said, we're not comfortable with this. We've never been trained. We don't understand the standard of care for this particular equipment and monitoring. And it turned out to be equipment and monitoring.
Mm-hmm.
And we are happy to learn it. However, at this point, we are not trained and we do not feel this is in the patient's best interest. So you will need to have another nurse from the ICU come down and be that equipment, monitor nurse, and we will do the obstetric part, the parts that we are trained for, and the parts that we are confident and skilled in, but not the hemodynamic monitoring that's invasive. And that's what changed. We got a team together. We trained. We put together an OB ICU curriculum and training program, and we developed a scope of service for our OB-ICU,
Mm-hmm.
the patients that we would take care of and those we would not. And some of the would nots were neuro patients, trauma patients, some of those patients. We still, even opening our OB-ICU, were not qualified to take care of major trauma or
Mm-hmm.
a neuro issue. But we knew what we could take care of, and we
That's a
trained
clearly
to that.
defined scope of service.
I know.
Yeah.
But it was the nurses that changed that to say, we're not skilled, we're not confident, and we will not do this. And nurses, you have more power than you think you do in that.
Absolutely.
But
Yeah.
it takes confident nurses and those who've been around for a while to speak up. It can't be that new grad on night shift by themselves to be the only one saying, I'm not confident in taking care of this. And, their assessment skills are probably better than a lot of people because they've just practiced them.
Yeah.
I think that nurses need to understand the systems and the processes on their unit. That scope of service is one of those, and to know what their resources are. And if they're not confident and comfortable, then they speak up about that.
I feel like your voice is really powerful in this because you've both of you, you've lived it. You've lived a change that you've made in clinical practice. You know how to influence change both through simulation and through, a team approach to trying to changing care. Can we talk about staffing?
Yeah.
And how this can-do attitude and staffing go together. And I'm gonna say, focus on nursing staffing at this point. I think the physician staffing is getting better with the advent of hospitalists in many hospitals 24/7. I think it was a real issue when hospitalists were not a thing. But I wanna focus on nursing staffing for a minute, especially with the new A1 guideline or standards, not guidelines. So, because we hear this all the time, we go to facilities, and we talk to nurses, we talk to teams, and some know what A1 standards are, and some don't. And sometimes it's a target, and sometimes it's not. But what does that look like at the bedside? Like, how does that impact risk for patients, for facilities? How does that impact, what can nurses do at the bedside? What does that look like? Because I think a lot of people are thinking it. They're like, I don't have a choice. I'm told my assignment and it doesn't meet A1 staffing standards.
Well, I'll start. Having been in nursing leadership roles and staff roles, it is really hard sometimes to meet A1 standards on staffing. We all get that. The pregnancy bus unloads at the triage and it trickles into labor and delivery. And those are not controllable. That is here in Nashville, it's a drop in the barometric pressure and everybody's water breaks and everybody shows up. And there's no predictive model to say everybody's coming in. We get that. But if it's a consistent issue on your unit that you cannot meet staffing standards that are published by A1 and that is your goal, then that's a different scenario, right? We all have that can-do attitude when the pregnancy bus unloads, right? And we have to prioritize those patients who need to be seen the quickest and who need a bed, so on and so forth, and who need the resources. But if it's a consistent issue, then I feel having been on the other side as the staff nurse, that we have a huge voice to say, we are not consistently meeting these A1 standards, and we are not comfortable in continuing to have, such high census and high acuity in our unit that we can't meet the standards. Because just because you have a consistent high acuity or high census on your unit and you're not meeting it, doesn't mean that the standard of care changes. That the same requirements need to be met to meet the needs of the patient at the time of whatever condition that they have. And you have to address the norms. You do have to have a flex plan on how you will flex staff. And let's get real here. Nobody flexes to labor and delivery. We may flex to some other unit, but nobody comes helping us in times of high census and high acuity. So what does that look like in your unit? And everybody's going to be a little different on that. At the same time, you can't have, 5 nurses sitting around with nothing to do.
Mm-hmm.
So what do you do in those times? it's a real pickle
Yeah.
for leaders. But again, what is your consistency? And as a leader, you need to know that. You need to know are we in this situation more times than not? Or what is the percentage of times that we don't have enough nurses and we've got to figure it out. And then we've got to request more nurses. And it's our job as a leader to get those and to make the point.
Do you think the OR is operating without circulating nurses?
No, I know, right?
When they don't have enough, we're just figuring it out and making it work. I mean, I'm sure the OR has their own challenges with staffing, but L&D is a critical place. I mean, I think that's great practical advice, but I would add that if you're, in leadership, and let's say you recognize this issue and you've been, talking to the high heavens and nobody's listening, you're not being supported, you're not getting the budgets, whatever, your risk manager is your best friend.
Mm-hmm.
Okay. Like, go through your processes, talk to your leadership, but risk management understands risk. That's their job. Yeah. And they may not even know there is such a thing as standards.
Yeah.
Right. And it is a risk because you and I know, since we do review legal cases, more and more attorneys on the plaintiff side are saying, we want your assignments for the day. You can, redact out any other patient name, but we want to know all the patients that were on the unit at that time that my patient who has an injury is that you were taking care of that patient. And we want to know your nurse assignment sheets, if there's a sheet. And we want to see if that nurse was taking care of any other patient at the time that this issue was going on that we've identified. And that happens all the time. And I review those, you review those. It comes up in deposition. Were you taking care of another patient on the unit at the time? Social media records are coming up. Phone records of the nurses at that time are coming up. Were you on your phone? Who is this call from? Who did you text? What were you doing to not see this category 3 strip that you should have been watching and intervening on? So there's a lot of issues, and it's a big deal. And I don't know. Sometimes, I mean, we've been in hospitals where the leadership is not L&D or has never worked in obstetrics too, which can be another big issue. They don't even understand the work that the nurses are doing and the physicians, and they don't understand the standards, and they're not members of A1. Like, how can you be a leader in obstetrics and not be a member of your professional organization? I'm just, it blows me away.
Yeah.
Well, I like the statement you said about they don't know the work, because I think we practice in obstetrics a lot of time from a historical perspective instead of a human factors or efficiency perspective. And when I got into simulation and saw how some of the units have worked to figure out what is their workload, how many people do they need in the room, what do those people need to do the job that they're there to do. I mean, if you look at, being from Indiana, if you look at the 500 and you look at the pit crews, they don't sit around and say, well, you're going to do this and I'm going to do that and let's see how it goes. No, it is orchestrated. It is like
Yes.
a choreographed dance, what they do. And they're very efficient, they're very fast, and they're accurate. And we have not done that work. So I think in some ways we haven't been given the tools, or we haven't been allowed the time to develop the strategies to figure out, if we have a severe hemorrhage coming in, we need X number of people. We need them to do this task. These are how the tasks need to be divided up so that their like tasks are put to one person, and one person is not overburdened with too many tasks that they can't do. So, we haven't done that basic work. I mean, we're starting in OB. I've worked with units that have started to do that basic work. That's, we just, again, figure it out. Can do. Everybody
still
runs
think
in the
so
room and tries to do what they need to do.
I still think so many people are focused on simulation as an education tool instead of as a problem-solving tool, like how it can really help them with processes and not teaching. I mean, it is very important for teaching, but it has so much more potential than just teaching. And Julie, you're so good at that aspect of it. And I
Thank you.
think people just need to, it's two different things.
It
Yeah.
is way two different things. It is so
Yeah.
opposite of what
Yeah.
I think most people are using it for. And we see that all the time when
Yeah.
we do run sims with teams, and you do, in the debrief, in their discussion, they're like, we've never really done this like this before.
Yeah.
We've never really thought of it as this. And they love it because what you're doing is you're trying to problem solve. You're
Mhm.
trying to figure out what makes their job easier. You're trying to figure out how to
Mhm.
make it work right,
Yeah.
and
Yeah.
that instead of having the can do attitude, you can't just wing it all
Yeah.
the time. We wing it all the time in hemorrhage. You know that
Yeah.
because when we do simulation, you see a lot of winging it, but it
Yeah.
makes you sit back and go, well, is that the reason that it's still outside of psych mental health issues and substance use, maternal deaths? Hemorrhage is the number one cause.
Well,
Yeah.
intrapartum for sure.
Yeah.
Yeah.
Using simulation to teach someone how to manage hemorrhage is a completely different scenario than figuring out what got in the way of effectively managing hemorrhage.
Right.
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 But we're not doing that work.
Mhm.
And
Okay,
I think there's just one more thought. There's this misunderstanding about simulation. Simulation for a learner, like a nursing student, is education. Simulation for someone who's got a license and is practicing should be all about efficiency, human performance, and application of what you've learned.
not to check a box either. Before we move on, Stephanie, can I add one thing I think that we're doing well we're not saying can do, and that is on inductions of labor. Everybody's being induced nowadays, every patient. And so they're backed up. They're all at home because you don't have any beds, because they're taking 4 days to deliver, and because they came in at closed cervix and all that stuff. But it's hard. You can't get them in. So I think two things that we've done with induction of labor that are good and not can do, and that is what is the process for bringing in the medical inductions, and the elective inductions at 39 weeks are not coming in ahead of those medical inductions. So there's usually a process in which how you address that, right? So that's one thing that I think that we've said, okay, we got to figure this out. And if you haven't, then after you listen to this,
It's
you need
time.
to do that, right? Because you can't.
This is your sign.
Wake-up call.
I know. And then the second one is in an induction of labor, if the unit is too crazy, that we usually have a process to say, I can't watch the Pitocin at this time, and we're going to shut it off until we can watch it close enough and assess the patient at intervals that we need to do. And again, that's a process that I think that we've done better and said, okay, enough's enough on this can do. We're not just going to keep the Pitocin running when we don't have anybody to watch it.
I mean, I've loved talking about this because, I've been part of the problem most of my career, I would say, in many ways. And sometimes I may have realized it and sometimes I didn't. And I hope that this is really resonating with people and figuring out, you don't have to say yes to everything, but I want to continue the conversation because we have an outline, guys, and we didn't even get to half of our outline because we've got so many opinions on this. So let's do a part 2 on this. We're going to have a can do part 2 coming up. So as always, we want to hear what you think. Please, listen and follow and like and review and all of the things. You can find us at clinicalconceptsinob.com to learn more about our CCOB Academy. You can hear more of us and learn more and get deeper at patreon.com/CCOB. And you can watch us instead of listen, or both, at YouTube and all of our social media channels. Stay connected. Let us know what you think. And most of all, thanks for being part of the podcast.